Hello, hello, RC Bhubaneswar. Are you listening to? Hello. Shall I start the session? RC Bhubaneswar. No, मैंने मुकेश आपने मस्सी हो गई तो अच्छा तो चैलेंज थैंक यू हेलो हेलो shall we start the session?
Yes, ma'am.
So my slides are visible to all of you.
Yes, ma'am.
Yes, ma'am.
Okay, so I have been given a task to take the session on the infection prevention and control and the impact of healthcare waste on human. Okay, so these two sessions I will be taking, and I will take you through what is called as the infection prevention and control, and how we can break the chain of transmission to prevent the infection. Okay. Anyone has joined from the RC Bhubaneswar? So I'm continuing with the session because uh, we are already, it is 4 past 15. So I'm starting it. Am I audible to everyone?
Yes, madam. Yes, ma'am.
Okay, fine. So I am Dr. Sumita Soni. I am working as an associate professor in Department of Microbiology and at BJ Medical College, and also the infection control officer at Civil Hospital Ahmedabad. Okay, and I am also one of the mentor for the state government of Gujarat for infection prevention and control, and also in the IPC program national body. Also, I am a part of that. Okay, so healthcare associated infection, basically it occurs in a patient when the ideally it was not present at that time when the patient admitted, so it is seen after 48 hours of admission, or we say that 2 calendar days of admission. Previously it was, now it is called as healthcare associated. Previously it was called as hospital infection, hospital acquired, or nosocomial. But now the terminology has newly been coined as healthcare associated. That means anything which is associated with healthcare leading to the infection is considered as a healthcare associated infection. It also includes the infection which is occupational infection among the healthcare providers. So most important for a healthcare associated infection to occur is the interaction of this epidemiological triad. So this epidemiological triad basically will, have three angles. The first one is called as a host, second is called as the environmental factors, and third is the agent. So host, most importantly, that When we are working in a hospital, we all do not get sick. The person, those who are the susceptible host, that means having the very poor nutritional status, comorbid patient, underlying disease, they all will catch the infection. They are very fragile and they will catch the infection. Second is the agent factor. So various type of the organism, bacteria, virus, fungus, parasite, they all are the agent. So these agent will infect the host. Environmental factors are the hospital's location, any chemotherapy going on, antibiotic therapy going on, any device you introduce, okay, central line, patient on ventilator. So these are the environment which is called to be conducive or favorable environment for the infection to occur. So when these three part of the triangle, interact with each other, it is the healthcare associated infection occurs. So mostly LMIC is the low middle income countries, and we come under that. And in our country, the burden of the healthcare infection is, you can see in the among the, so we can see the large dots. So even in the, if you see India, it is 6 to 10 and more than 10 for the adults. Okay, so it is a grave situation. In our country, in all the countries, 7 to 10% of 100 hospitalized patient catches infection, 7 in the high income and 10 in the low and middle income country. 1 in 4 will acquire infection in the long term setting, like in a hospitals, caused by the multi-drug resistant organism, and 1 in 3 in the ICU catches the healthcare associated infection. So this scenario says that it is, like we are in a very bad situation. Healthcare associated infection causes, a lot of impact on the public health. So it increases the morbidity, means the pain and the, increased length of stay and all it can cause. If it is the infection is caused by the multi drug resistant organism, mortality is also seen, quality of life will be hampered, and the patient safety is also impaired. Healthcare associated infection causes long term disability and increased resistance of the microorganism to the antimicrobial agent, and also increases the cost, direct and indirect both. Because once the patient is admitted, direct cost, like we are in a, I work in a government setting, so in our hospital we do not charge anything. But if they are in a hospital setting, in a corporate or a private, they will definitely be charging for it. So each antimicrobial agent is being charged, hospital beds are charged, so it increases the length of stay, so charges are going to increase. And that particular person is not able to earn for his family, so this is the indirect cost also increases. So most important part of the healthcare associated infection is that it is a preventable, it is a disease, it is not a disease, it is a condition. We can say it is preventable through the effective infection prevention and control measures. So under the patient safety also, in the national framework, it is one of the important goals, that is control of the healthcare associated infection. Okay. So how we can control it? Most important part is to control is to break the chain of transmission. How can we break the chain of transmission? It is through, so these are the different links. So infectious agent, host and reservoir, I have already told you. These agent will come out of the patient's body, that is called as portal of exit. These are transmitted through many ways, that is modes of transmission and portal of entry. They can enter inside the body. So, like if we call that infectious agent, rapid diagnosis and killing that organism will prevent the other person from getting infected. Cleaning, so they lie in the reservoir, in the environment of the hospital. So cleaning and disinfection also become very, very important. Sterilization, disinfectant, portal of entry. So proper attire, like surgical, if you see that in a surgery, before surgery, surgical scrub is done, proper attire is being worn, so that the infection doesn't occur to the patient, and we are using each and everything in a sterile way. Hand washing, is one of the most important tool, or we'll say weapon, against the healthcare associated infection. Appropriate waste disposal of the biomedical waste, control of the excretions and secretions, transmission. We can, by hand washing, we can control the transmission of the infection, by food, by isolation precaution. Total of exit is the wound care, catheter care, and the various sterilization, aseptic technique. Okay, and then treating the host. So underlying disease makes it more susceptible. So like that. Infection prevention and control plan is basically a smart plan. So surveillance, monitoring and auditing, antibiotic policy, reporting of the outbreak management, and training of the staff, as well as the other those who are related to it. So, to set up an infection prevention and control program, we need to have a documented, laid down program for the for the prevention of healthcare associated infection, and this is this comprises of the first part of it, that we need to have a documented program. Okay, so there should be one HIC manual or IPC manual, wherein we have to clearly lay down our aims and objective, the processes, the surveillance activities which we are going to conduct, and we also need to update this update this based on the developments, based on the current updates in the newer guidelines coming down. So we need to have a written guidance and also need to update it. Hello. Yes. नहीं, आप कौन बोल रहे हो? मैडम अभी मैं एक है ना ऑनलाइन लेक्चर में हूँ, मैं आपको कॉल बैक देती हूँ. हाँ. So, so we need to have an written infection prevention control program, which needs to be updated at least on a yearly basis. We also need to lay down our high risk activities, and also need to define our high risk areas where we know that there is more risk of transmission of infection. So aerosol generating procedure like intubation of the patient, handling, body fluids, spills, decontaminated medical device, biomedical waste. So these are all very high risk activities. These needs to be reviewed once a year based on the new literature or infection trends and outcome of the audits. We also need to assess our organization based on the tool which is called as the IPCAF tool, or WHO's, that is infection prevention and control assessment tool for the facility level, or CDC tool also you can use, so that we know where we are standing. And we know they have got 8 different domains, so we know that which domain we are strong, which domain we need to improve. So they have given the domains. For each domain they have given a marking system also, and depending upon those marking system, they increase marking system. We do our baseline assessment, and what are our improvement areas we will come to know. To implement this entire program, though even though we lay down our manual, it will not be implemented. So we need to have the 2 core component of it. One is laying down of a multidisciplinary infection prevention and control committee and infection prevention and control team. Okay, so committee mostly is led by the chief of the hospital or medical superintendent. Microbiologist or infectious disease specialist are considered as one of the key person, member secretary for this. All clinical persons representatives should be there. Infection control officer, infection control nurse, nursing representative should be there. Someone from the CSSD, OT and ICU should be present. Support staff. So IPC practice is not only about, the clinical services. It is also about the services which are the admin, I will say the support services, and these support services includes the security. It also includes your maintenance department, biomedical engineering department, housekeeping department. So these are very key important support services which are also to be also to be asked to be the part of the infection control committee. Invitees from other department, if you think, you can invite them. And we need to lay down our risk reduction goal with a measurable objective, and we need to review it every monthly. This committee needs to meet every monthly, and minimum quorum is required. You can decide the quorum, like 80% of the members should be there. Most important, that decision making members should be present in the committee meeting, so that the committee meeting is not just for a meeting purpose, but the agendas are discussed and some concrete decisions are also taken. The entire meeting needs to be minutized and circulated to all members. Okay, infection control team is a team which basically looks into the day-to-day functioning of the infection control program and supporting the surveillance process. And if any outbreak happens, doing the outbreak investigation, participating in the audit activities. Okay, so minimum infection control team should comprise of the infection control officer and nurse. But I would recommend that a nursing from the nursing department representation should be there. There should also be from the sanitary department or from the housekeeping department, because these are the persons, those who are day in day out helping in implementation of the infection prevention and control program. So, who should be the infection control officer? A microbiologist or infectious disease specialist. An infection control nurse should be a registered nurse, have undergone a structured training on the IPC practices, and he or she must be doing the hand hygiene, compliance monitoring, transmission based isolation precaution, sterilization, disinfection, and hospital acquired infection surveillance. So these are minimum 1 in 250 beds, one infection control nurse is needed. If your hospital is a busy one, you can designate the link nurses to help those infection control nurses. Then this outbreak investigation is one of the very very important part of the infection control program. Most important is that your management should be committed to provide the resources for the IPC program. Otherwise, it will not work out. So, availability of the men, material, and resources are needed in a sustainable manner by the management. So, if I talk about the hand hygiene, if you don't have the water supply, there is no point. If you don't have the hand wash, liquid hand wash, availability of the liquid hand wash, even though we train entire staff, they will not be able to practice it. Okay, allocated fund should be there for the infection prevention and control program, and ensure the availability of all these personal protective equipment, adequate inventory, gown, mask, and all. So these are all important things. Facilities for the hand hygiene should be available inside the hospital, like wash basins, hands-free tap, and drying of the hands without getting it contaminated. Liquid soap should be available. In the ICUs, hand rub availability in between each patient should be there. So these, at least these are some important resource point of view availability, which to carry out the IPC practices, these are mandated and needed. There is something called as the isolation precaution or the barrier nursing, wherein this is mostly required for. There are two types of the barrier nursing. One is the barrier nursing, and second is the reverse barrier nursing. So barrier nursing is a part and parcel of the isolation precaution. And when you think that your patient needs isolation, so like contact, droplet, and airborne precaution like swine flu, tuberculosis, we keep them in a separate room with a negative pressure, and there is a IL room separately, and you do not directly enter into it. There is all restricted area displays are there, and you wear the appropriate PPE and then only enter inside it. The reverse barrier is something wherein your patient is immunocompromised, like transplant patient, like bone marrow transplant or other transplant patient. Therein you wear the entire PPE and you are wearing, and they are positive pressure room, and therein you are going to those rooms wearing the PPE to save those patients rather than to save yourself, because they are more vulnerable category of the patient. Then adhering to the standard precaution in all areas of the organization and all at all times. Okay, hand hygiene adherence is something which is very, I'll say, the one of the simplest solution to reduce the transmission of infection, and also to also to decrease the rate of the healthcare associated infection. Okay, so display is necessary in all areas. So these are the five moments, like before touching a patient, before, after touching a patient, before clean and aseptic procedure, after blood and body fluid exposure, and after touching the patient surrounding. Types of the hand hygiene are the social hygienic and the surgical hand wash. And you can do the wash when it is visibly contaminated with the liquid soap and water. Alcohol based hand rub is in between the patient. You can use inside the ICUs. And surgical scrub, wherein you have to vigorously clean your hands before going for any surgery or any aseptic procedure. So these are all steps of the hand hygiene and hand rubs, and these are the actual steps. And this is the surgical scrub. You have seen that they are not touching the taps, so they are all sensor operated or foot operated taps. Transmission based precaution, we have the airborne, droplet, and the contact precaution. Okay, so airborne and the droplet are the respiratory diseases, so swine flu and the tuberculosis. And contact precaution, measles, mumps, and any scabies or skin diseases. Also, the adherence to the safe infection and infusion practices, we need to have, it is a part of the infection prevention and control program. So safe injection practices, and it is the mantra is one needle, one syringe, and only one time. So we do not, no one advocates to reuse the needle, and as soon as you use the needle, you need to cut it, and you need to put it inside the punch-proof container. Antimicrobial uses policy, so every hospital need to have an antibiotic policy, and which the newer guideline for by the NCDC and the ICMR has been laid down in recent past. You can Google it and you can download it, and there should be justification of why you are using the antibiotic. So infection prevention and control program, the sub program or the other branch of it is the antimicrobial stewardship program. Okay, so we need to have a system to monitor whether the antibiotic is being rationally used or not. So the microbiologist will help you in this, and you can refer to these guidelines. The newer guidelines have come. Then rational use of the antibiotic, we need to also have a list of the restricted antibiotic, because we all know that we have been rampantly using the antibiotic. Kerala is one state wherein you don't get the over the counter drug antibiotic, and if anyone prescribes it or issues it, if a pharmacist, they will be punished. So even I think even it has been initiated in Punjab, but we are far behind the western countries in rational use of the antibiotic. We also need to prepare a list of the antibiotic which are restricted antibiotic, whereas you need to take permissions from them, some higher official, as well as you need to justify why you want to put your patient on these high end antibiotics. Okay, so in the ICUs there is there is all sort of practices are there, that we are using the cocktail therapy. So all mix of antibiotic at one go only we start, whatever is useful is useful. No, it's not like that. We need to start with the empirical therapy by the culture and sensitivity report. We need to narrow down if the sensitive drugs are coming. Okay, and then this is antibiotic stewardship program, which is also part and parcel of the infection prevention and control program. I already told you the support services. Support services are one of the important support services is the engineering, biomedical engineering and engineering department. So, hospital is designed in such a way that in between the two cots, 2 meter spacing is there, operation rooms, HEPA filter, maintenance of the heating maintenance and heating maintenance and air conditioning guideline, duct cleaning, so water supply, water management, testing of the water quality. So these all comes under the engineering control of to prevent the infection. You can refer to the NABH OT guidelines, and even the government of India has also released the guidelines. NHSRC has released. You can refer to that. Okay. Whenever there is any construction is going on, so there is a little risk of increasing the infection during this renovation. So because when you do all this construction work, the spores are going to form. So we need to do a pre-construction risk assessment, that is called as PICRA, and infection control risk assessment, to take the preventive measures, so that like in a hospital, you want to open a new ward. Okay, so it's a running hospital, you want to open a new ward, you need to take all the precautions so that it doesn't spread to the other area of the hospital which is already running. Okay, so this is called as a ICRA, infection control risk assessment. Also, we need to have a housekeeping manual. You can refer to the housekeeping guidelines of the Swachhta Mission, wherein we divide the area into the high risk, low risk, and medium risk areas. Okay, according to the risk of the transmission of the infection. So in the ICU, we need to do the cleaning more frequently with the hospital approved disinfectant solution, and we can divide this area depending upon the risk matrix. Okay. So common disinfectant and their dilution protocols we need to lay down. We need to train each and every staff, those housekeeping staff, how to do that. Even a single mopping also we need to train that it has to be in a figure of eight, inside out, not outside in. So these are very small techniques, but these are very, very important. How to clean the blood and body fluid spills, terminal cleaning when the patient dies or they are discharged. So these are all protocols should be laid down. Then the biomedical waste management, I am not going into the detail because your entire module is dependent, going to be discussed on it. Most important is that while handling it, we need to wear the PPE. Biomedical waste has to be segregated in the patient care areas as per statutory guideline in the color coded bags and bins, and then as stored not beyond 48, not beyond even 24 hours in the temporary storage area, and has to be handed over to the common biomedical waste treatment facility. Then linen is one of the very important source of infection in the patient care area. Every day the linen needs to be changed. So in government of India has released a color coded linen guidelines. So the color coding has been given that day one it will be white, then blue, then different color. So you need to paste it in each ward, that color coding, and you need to audit it also. So when you go and see that if the if some different color linen is there, apart from or one or two beds, if it has not been changed, you will be able to visually identify it very easily. And it is not only once a day linen change. If it is dirty, if it is full of secretion and all, we need to change the linen. Okay, linen and laundry can be outsourced or in-house also. So these infected linen need to be pre-treated. Okay, you can treat it with a 0.5 you can treat it with a 0.5% sodium hypochlorite, and then you can send it separately. So it has to be transported in a yellow bag, and separately it has to be sent to the laundry. Okay, then kitchen is one of the food handling, because it's one of the source of infection. So kitchen workers needs to be screened for any of the infection, and we need to have a separate food preparation area. Crisscross traffic needs to be prevented, and all activities in a sequence. Kitchen can also be outsourced or in-house, doesn't matter. but we need to, if it is a outsourced, we need to visit the kitchen and see once in, at least once in a year, that whether they are having a dry storage, wet storage, their all instruments are working or not, how they are supplying it to us, so these all parts we need to. Storage and refrigeration conditions, and products should be stored off floor. The dry store, how they are storing the dry items, and and it refers to the FSSAI guidelines. So any kitchen needs to be FSSAI, should have FSSAI license. Okay, temperature controlled food trolleys for the temperature sensitive food, they need to use it for the distribution. Then there are four type of the infection which we need to monitor as a part of the healthcare associated infection. So out of them, the three are the device associated and one is the procedure associated. So device, it is said that when you use a medical device like catheter, ventilator, central line, so the risk of infection increases. So adhering to the basic principle of the infection control, infection control, we can prepare a care bundle. Okay, these are the group of the I'll say the group of the infection prevention control practices which are grouped together to prevent. If I say the patient is catheterized, COTI, their catheter associated urinary tract infection. So these care bundles can be divided into three parts. One is the insertion care bundle, maintenance bundle, and the removal care bundle. So at one go, every day you need to monitor them, and then you need to adhere to these care bundle. The same is for the ventilator associated pneumonia, and the same is for the central line associated bloodstream infection. Adhering to this is one which is a procedure associated infection, and here the care bundles are the pre-op, intra-op, and the post-op measures which we are taking so that we prevent the surgical site infection. So these are the surgical site infection prevention, and its monitoring does not restrict only to the hospital admission. Even beyond that, 30 days surveillance and 90 days surveillance we are supposed to do depending upon the type of the surgery. uh, you know uh, Doing the infection prevention and surveillance of the infection prevention and control, and analyzing the risk rates and trend. So why we are doing the surveillance, it is to know how, what are our rates and how we can reduce it. So the most important is the reduction of the rate. So most important, whatever the surveillance we are doing, we need to verify the data by our IPC team by using the random sampling, or anyone can anyone can I'll say that verify it, but they should be the team member, or someone outside the team member also, those who are trained to do the verification of the data. So mostly the ICN verifies, and infection control officer also verifies it. And then surveillance should be directed to the high risk activities. So I have told you some example, that is demolition, constructions, and the repairs. And the frequency and mode of surveillance we can depend upon our requirement. Hand hygiene surveillance is one of the part of the surveillance. So we need to choose appropriate sample size. It needs to be done every monthly, and you can refer to the WHO's hand hygiene observation form. Surveillance includes the multi-drug resistant surveillance also. So your microbiology report, you need to analyze it properly so that you know that this is a patient which is MD, which is having the infection of the methicillin resistant organism, or vancomycin resistant, or multi-drug gram negative, and you need to take the preventive measures also for that. Then effectiveness of the housekeeping also we need to see. So it is not only the checklist like toilet cleaning and its checklist. It is randomly, the infection control team visits this, and they are doing the audit of this housekeeping activity. So this audit can be, you go to that random area. If it is generally not clean, we know that the housekeeping activities are not being appropriately done. Feedback regarding this to the appropriate healthcare worker is very, very important, because whatever the rates we are calculating, if we don't give the generate a feedback for those who are responsible for this, they will not come to know. that what are their fallacies and how they need to improve. Then outbreak investigations as per the WHO guideline, early identification, and then we need to define the outbreak, and then we need to have a outbreak investigation guidelines depending upon that. And surveillance data are analyzed, then corrective and preventive actions are supposed to be taken. One of the most important part of the infection prevention and control program is the Central Sterile Supply Department, that is CSSD. So supplying disinfection and the sterilization. So CSSD department is also called as a five-star kitchen of a hospital, and it has to have a unilateral flow, and it has to have a segregated areas. Okay, so proper zoning, we say unidirectional flow along with the zoning. So it has a cleaning area, drying area, packaging area, sterilization area, storage area, and issue counter. And there should be the barrier between the soil zone, clean zone, and the sterile zone, and sufficient space should be there, and dirty and clean should not be mixed. So these are cleaning and disinfection and sterilization guideline. We also need to, so this is the Spalding classification, wherein depending upon the type of the contact, the device are classified critical, non-critical, and semi-critical. Critical device needs sterilization, others can have the high level disinfection and the intermediate level disinfection or low level disinfection. Basically, if you can sterilize anything, it is well and good. Sterilization, the by definition, it is says that you remove the article surface and the medium from all the microorganism, including its spores. Okay, so spores also are killed in the sterilization process. So this is CSSD guidelines. So we need to have a written CSSD manual, and disinfect guideline has to be there. Storage guideline also has to be there. Storage guidelines are applicable across the organization. So when these are sterile items are issued outside the CSSD, they are kept in the ward and the OT. These guidelines are applicable to it. Expiry date are supposed to be there. Mode of sterilization are to be there. Okay, and reuse, we are not a very rich country, so single use devices are many a times reused. So there are guidelines how many times you will be reusing it, how you will be monitoring the process of the reuse. So these all are needs to be laid down in the manual. Okay, and then the validation of your CSSD, sterilization process. Okay, so physical validation means temperature, pressure, and time record chart, which has to be daily. Chemical validation also has to be daily, and biological at least weekly by the bacteriological, engineering by Bovidic and the leak rate test. Okay, so these needs to be done. If there is any breakdown, like if these all validation fails, then we need to recall all the loads. Okay, so we need to have a recall policy and have a batch processing system with a date and machine number for the effective recall. Because if you have not written anything, you don't know where it has gone and how you want to recall it. Because if its validation has failed, means the sterilization process was inappropriate, and it was ineffective. Okay, so you need to call the entire load back. Even the moisture is there, you need to call that load back, and then you have to keep it, you have to open it, then wash it again, dry it, pack it, and do the sterilization again. And also you need to see that which machine has failed, why it has failed. Okay, so healthcare, IPC practices also includes the occupational health and safety. So it includes the adequate provision of the resources, standard precaution, employee screening, health screening, and their immunization. So by and large, we give the hepatitis B immunization. Like in our laboratories, we have a polio lab, so we give the oral polio vaccine, and we also have Maru online lecture challenge. Hmm. Hmm. Provide as per the risk in accordance with the other relevant immunization. Okay, so like COVID immunization, you can, in the COVID era, it has been given tetanus. Definitely, tetanus is one of the recommended immunization. Okay, and then work restriction policy we need to prepare. So what are the work restriction policy? Basically limiting the role of the infected staff. Like if we are having the cough and cold, acute conjunctivitis and all, we should not allow those patient those staff to work in a open areas, in a clinical areas. So give them some admin work so that the others are not infected. And use of the appropriate personal protective equipment and needle safety devices, and post exposure prophylaxis if the needle stick injury occurs. Post exposure prophylaxis guideline refers to the NACO guidelines, and we should follow that only. So this is all about the. Oh, okay, so this is all the breaking the chain of transmission of the infection, and thank you so much. Uh, I'll take you through the another session. We'll be taking the question answers lastly so that we can quickly run through the another session, which is. My screen is visible.
Yes, ma'am.
Yes, ma'am.
Okay, fine. Okay, so mostly we will be talking about the impact of the healthcare waste on the human health, and I will quickly take you through this. These are the snapshots from our course material only. We'll be discussing few part of it, and mostly, that we all know that the healthcare waste, if it is not handled appropriately, it causes a lot of hazards, including the hazard to the human health. Uh, you know so they causes a lot of risk to the hands of the healthcare personnel. These comprises of the laboratory waste, the waste contaminated blood, body fluid, needle sharps, and poorly clean surfaces. So these are all the the source of the biomedical waste, and they are reason for the disease transmission. So, one most important thing is the handling of the sharp. So, if you don't if you are not handling the sharps appropriately, it can lead to the needle-stick injury. And these all, if they are not handled in a safe way, in a puncture-proof, tamper-proof container, they may lead to the needle-stick injury, and it can cause a very big hazard in terms of hepatitis B and the HIV infection. So HIV, mostly we say that HIV infection is not that much like the transmission of the HIV is not uh, HIV transmission rates and risk are lesser than the hepatitis B and the hepatitis C transmission. But these are all transfusion transmitted infection, or they are transmitted through the blood and the body fluid or through the needle stick injuries. Okay. So this risk to the healthcare staff, we all know that they can have the risk of the blood and the infectious spills, pathogenic aerosols, maybe the needle stick injury also. They also comprises the risk to the patient visitors. Okay, so people, those who are visiting us, like patient relatives and all, those who are the visitors, they may also get, if they are susceptible, they may also catch the infection. And also the healthcare workers, it is a big risk. And to those who are, the scavengers and informal recyclers, those who are handling it, the rack pickers and all, so this is a big risk to them also. And this is the risk to the waste handler, risk to the community also. If I'll say that if they are not segregated and discarded, what will happen, the entire general waste will come down to the biomedical, will be converted into the 100% of the biomedical waste. And they will, if they are just thrown like that, along with the general waste, it will be a big risk to the community also. Okay, so broken sharp, the needles and syringes and all. Okay, and a risk to the waste handlers, that is immediate risk due to the injury of the sharp, and toxic things out of those waste, risk can be there. Now we have come to know that these are the definite these are the uh, cadre of the staff, or I'll say the cadre of the level of the people, those who are at risk with the biomedical waste, or a healthcare associated waste. But what are the risks? So most important risk is the commonly transmitted infection, that is hepatitis B, hepatitis C, and the HIV virus. Among 35 million healthcare workers, it has been seen, and estimates that 3 million receive because bloodborne pathogen, and 2 million are because of the hepatitis B, and zero point 0.9 with the HCV, and lesser than that is the HIV. How infectious waste management leads to the reduction of this risk. So we need to very much assess the risk of this, and we need to save the humankind uh, against this risk. Okay, so if I give you the example of the sharp, all the needle, hypodermic needle blades and knives and glass pipettes and all needs to be discarded in the puncture-proof, tamper-proof containers. Otherwise, there is a big risk of the healthcare associated with. I am working in a microbiology lab. The culture and the stock material, they are also a big risk to, if they are not pre-treated, and they are discarded just like that, it can lead to a big outbreak of the disease also. So using a personal protective equipment to prevent the aerosols, and also autoclaving these waste are very important. Then blood and body fluid exposure can also lead to a lot of risk of the transmission of the disease, and pathological and the placental waste. So these all waste, those who are having a high risk, they all are actually being incinerated, so that they are reduced to, risk is reduced to zero for the transmission to the public health or to the mankind. you know uh, then wastewater is also a risk. So because it carries a lot of organism, it carries, so the effluent treatment is also one of the way of effluent treatment plant, and the STP, that another entire lecture will be there for you, that is a sewerage treatment plant. So these reduces and make this water uh, uh, you know less risky to be put in the direct common sewer line or drained in the direct common sewer line. Impact of the infectious healthcare waste in the public health is, I have told you, see this hepatitis B, C, and HIV. And also nowadays it is the antibiotic resistance, which is very much, drug resistant organism are in all the surface and everywhere. So they can, there are all chances that this it spreads. An impact of the infectious healthcare waste on the environment is that, your environment dumping, improper segregation will lead to, making it very unsightly and objectionable. And apart from that, uh, the microorganisms will grow into it and it will spread in the common public. So these are all types of the risk and prevention. We need to prevent the policy wise. So this I have taken in the IPC program, that we need to design a program and, plan and train everyone so that the risk is reduced. So, appropriate sharp waste management, standard precaution, barrier nursing, and effective management of the spill and accidents and the wastewater management as per the rules. So, these are all the risk to the humankind. I think that's it from my side. And if you have any question answers, we can take it up. Hello. Hello.
Hello, yes, ma'am.
Yes.
Yes, ma'am. You spoke about laundry, and
Hmm.
if we have a separate washing machine in a particular separate department, then should we maintain record for that, ma'am? Whatever put into laundry
Yeah, yeah. Separate what? See, if you have an
and clothes
in-house
of that
laundry,
particular department
you
will
need
not
to
be
have a
mixing together.
protocol.
Ma'am.
I am not able to understand your question. Will you please clarify it?
Yes, ma'am. Sure. You spoke about laundry, and
Hmm.
in a particular department, for instance, working in OT. Operation
Hmm.
theater. We have a separate washing machine for operation theater. So whatever the
Okay.
linen we are soiled and not soiled, whatever we put for washing in the particular same department in OT itself, and we put it for
Hmm.
drying, and we keep in it, for it ourselves. So that those clothes are not going to be mixed with the other departments. So should we have a separate documentation for that, like how we do
See,
in other
one thing is
departments?
that whatever you are practicing is not correct in terms that you have to have a washing machine cycle wherein, see, there are two types of the linen. One is the infected linen and one is a not infected and used linen. Okay.
Yes,
So
ma'am.
used linen, you can wash it with the soap and water. That is absolutely fine. For
Hmm.
infected linen, you need to have a separate protocol, like with the 0.5% sodium hypochlorite. You need to soak it at 1.5 to 1% sodium hypochlorite for half an hour. Or you can, push, you can use the sodium hypochlorite in the washing machine cycles also, but you cannot
Huh.
mix those two cycles together.
Yes, ma'am.
And
We
you
are
have to
not
have a
mixing.
record keeping,
Huh.
for
Huh.
all.
Okay, okay. We are not mixing, ma'am. We are doing it separate. Soil linen and used linen, that
Yeah,
is
even if you are
infected
doing
linen,
separate,
separate. Yeah.
you need to have
Okay.
a protocol, that
Yes, ma'am.
and you have an in-house laundry or you have a outsourced laundry, because you won't be ironing it and calendaring it and all, na?
Laundry, ma'am.
You have a in-house or outsource?
Huh. We have in-house laundry, ma'am.
You have in-house laundry. So how
Yes, ma'am.
washing it in a washing machine will not will not, suffice all the steps, like ironing and calendaring and all. These are also the part of the laundry management only. Do you have it?
Okay.
Have you got it all separately?
Yes,
In
ma'am. For
house,
OT
see, in
department, we
house,
have. Huh.
Yeah,
Huh.
please tell.
For OT, we have everything
Hmm.
separate. We'll not mix the OT clothes with the other department clothes. Other departments have
Hmm.
one in-house laundry. So in OT,
Okay.
we have a separate
Hmm.
washing machine. So whatever soil linen, we treat it with
Hmm.
0.5% hypochlorite for half an hour,
Hmm.
and then
Hmm.
put it for
Hmm.
washing, and then we dry it, and then we use it.
Hmm. So
And
that is
other used
absolutely fine, but you
linen,
have to have a record
yes,
of
ma'am.
that.
Yes,
Okay.
ma'am. Okay, ma'am.
Someone has raised
Thank you, ma'am.
quality cell. Not able to listen to your voice. Please unmute
Yes,
yourself.
good evening, ma'am.
Yeah, good evening.
Ma'am, I am Dr. Shwetambari from Chandigarh. So I'm looking after the biomedical waste. I'm the nodal officer
Hmm.
here. With
Okay.
regard, thank you so much for your very nice presentation and lecture, ma'am. So one query that I wanted to ask was that we have outsourced the laundry for our hospital.
Okay.
And we have, as a team from the quality and infection prevention and control nodal officers, we have visited the facility which is given the contract also.
Okay.
The thing was, ma'am, that we are just collecting the dirty linen into bags and tying it and sending it to the outsource agency.
Okay.
We are not treating it before sending.
So if you have a facility to pre-treat it, that is well and good. Otherwise, you need to have a mechanism, because every day you cannot go there, and visit them, and every day you cannot ensure that they have pre-treated it or not. Because for
Haji, but
infected linen, we need to pre-treat it so that it becomes non-infectious once it goes outside your premises. So that is what is the requirement. Okay,
okay,
so
because when we
you
visited,
can pre-treat,
huh,
and you can have make a separate bag and ask them to wash it separately in the last cycle.
okay, because they have the procedure there where they are pre-treating it
But
and
every day, I think, are you visiting them, or how oftenly?
ma'am,
So that
we
is
are
not.
not visiting them every day. We just visited
uh,
as a team, like once in 6 months or so,
That's what.
as
So,
an audit team.
even if they say they may not, they may be mixing it. So, to be on safer side, if we pre-treat at our own premises, it is well and good.
Okay, thank you.
Any other questions? If we don't have any other question, we may close the session, because I am done with from my side. Hello.
No queries, ma'am. Thank you, ma'am.
Okay. RC Bhubaneswar, shall I close? Because they are the organizers. Classroom 2, RC Bhubaneswar. Has anybody joined? I don't know. I hope I was able to clarify all your doubts, and see you in some next sessions. Thank you so much. Thank you.
Thank you,
Thank
ma'am.
you, ma'am.
Thank you.
Thank you, ma'am.